Welcome to On Obs and Gynae. Today we will be discussing the NICE 2019 guideline for twins and triplet pregnancy with the latest 2024 update. In this video, we will break down the key recommendations so you can understand antenatal surveillance, time of delivery, and risk-based care pathways for both twins and triplets. So let's get started. First, we will study determining the gestational age and chorionicity. For gestational age, offer women with a twins or triplet pregnancy a first trimester ultrasound scan to estimate gestation age and determine the chorionicity and amnionicity. Estimate gestation age from the largest baby in the twins or triplet pregnancy to avoid the risk of estimating it from the baby with early growth pathology. Next is chorionicity and amnionicity. Determine chorionicity and amnionicity at the time of detecting a twins or triplet pregnancy by ultrasound using the number of placental masses, the presence of the amniotic membrane and membrane thickness, the lambda or the T sign, and the discordant fetal sex. Assign nomenclature to the babies, for example, upper and lower, right and left in a twins or triplet pregnancy, and document this clearly in the woman's note to ensure consistency throughout the pregnancy. If a woman with a twins or triplet pregnancy presents after 14 weeks, determine chorionicity and amnionicity at the earliest opportunity by ultrasound. If it is not possible to determine the chorionicity or amnionicity by the ultrasound at the time of detecting the twins or triplet pregnancy, seek a second opinion from the senior sonographer or refer the woman to a healthcare professional who is competent in determining the chorionicity and amnionicity by ultrasound scan as soon as possible. If it is difficult to determine the chorionicity, even after referral, for example, because the woman has booked late in the pregnancy, manage the pregnancy as monochorionic pregnancy until proven otherwise. Provide regular training so that sonographer can identify the lambda or the T signs accurately and confidently. And a less experienced sonographer should have support from the senior colleagues. Now, provide regular training to the sonographers. And training should cover the ultrasound scan measurement needed for women who booked after 14 weeks and should emphasize that the risk associated with the twins or triplet pregnancy are determined by chorionicity and not the zygosity. Conduct clinical audit to evaluate the accuracy of determining the chorionicity and amnionicity. If the transabdominal ultrasound scan views are poor because of retroverted uterus or high BMI, TVS is used to determine the chorionicity and amnionicity. Do not use the 3D ultrasound scans to determine the chorionicity and amnionicity. Networks should agree the care pathways for managing all the twins and the triplet pregnancies to ensure that each woman has a care plan in place that is appropriate for chorionicity and amnionicity of her pregnancy. So, how would you provide the general care? First of all, information and emotional support is very important. Explain sensitively the aims and possible outcomes of all screening and diagnostic tests to the woman with a twins or triplet pregnancy to minimize their anxiety. Diet, lifestyle, and nutrition supplements are very important. Give the woman with multiple pregnancies some advice about all these things. Be aware that there is high risk of anemia and perform full blood count at 20 to 24 weeks of gestation to determine to identify the women with a twins or triplet pregnancy who needs supplements or the correction of anemia. Now we will talk about the delivery of antenatal and intrapartum care. In the antenatal care, women with a twin or triplet pregnancy should be nominated to the MDT. The multidisciplinary team consists of a core team of named specialist obstetricians, specialist midwives, and sonographers, and also an enhanced team for referral should include perinatal mental health professionals and dietitians, etc. Members of the enhanced team should have experience and knowledge relevant to the twins and triplet pregnancies. Do not routinely refer all the women with the twins or triplet pregnancy to the enhanced team, but base the decision to refer on each woman's need. and coordinate the clinical care for the woman with the twins or triplet pregnancy to minimize the number of the hospital visits, provide care as close to the woman's home as possible, and provide opportunity of the care within and between the hospitals and the community. The core team should offer information and emotional support specific to the twins and triplet pregnancy at their first contact with the women and provide ongoing opportunities for further discussion and advice, including antenatal and postnatal mental health and well-being, antenatal nutrition, the risks, symptoms, and sign of preterm labor and potential needs for the corticosteroids for the lung maturation and likely timing of the birth, breastfeeding, and parenting. Now we will talk about the intrapartum care. Intrapartum care for the woman with twins or triplet pregnancy should be provided by multidisciplinary team of obstetrician and midwife who have experience and knowledge of managing twins and triplet pregnancy in the intrapartum period. Now, this is the schedule of specialist antenatal appointments. Now we will talk about the diachorionic diamniotic twin pregnancy. Offer the woman with such pregnancies 8 antenatal appointment with the healthcare professional from the core team. At least 2 of these appointments should be with a specialist obstetrician. Now, in the monochorionic diamniotic twin pregnancy, offer 11 antenatal appointments. 2 of these should be with a specialist obstetrician, in which we combine the scan for CRL, which measures from 45 to 84 approximately 11 to 14 weeks, and then at estimated gestation of 16, 18, 20, 22, 24, 26, 28, 30, 32, and 34 weeks. So 11 appointments in total in such case. In case of the triamniotic triplet pregnancy, that is trichorionic diamniotic or monochorionic, there should be 9 antenatal appointments. 2 of these should be with a specialist obstetrician, and in such case combined appointment with the scan when the CRL measures between 45 to 84 at approximately 11 plus 2 to 14 weeks. That would be the first scan, and then at estimated gestation of 20, 24, 26, 28, 30, 32, and 34 weeks, and offer an additional scan, additional appointment without scan at 16 weeks. So total 9 appointments should be there in such case. Now, offer the woman with a dichorionic triamniotic or monochorionic triamniotic triplet pregnancy at least 11 appointments, and at least 5 of these should be with the specialist obstetrician, and that include the initial appointment when the CRL between 45 to 84 at approximately 11 plus 2 to 14 weeks. That is should be the first one, and then at estimated gestations of 16, 18, 20, 22, 24, 26, 28, 30, 32, and 34 weeks. So 11 antenatal appointments in such case. Now, in case of the twins and triplet pregnancy with a shared amnion, an individualized care from consultant in the tertiary level fetal medicine center should be provided. Now we will discuss the fetal complications. Information about the screening should be provided. A healthcare professional with experience of caring for the woman with a twins or triplet pregnancy should offer information and counseling to the woman before and after each screening test. Now, screening for the chromosomal conditions should be there. In case of the twins pregnancy, offer information about the screening for the Down, Edward, and Fetal syndrome outlined in NHS Fetal Anomaly Screening Program. Now, triplet pregnancy. Before offering screening for the Down, Edward, and Fetal syndrome, give women with a triplet pregnancy information about the greater likelihood of the Down syndrome, Edward syndrome, and Fetal syndrome, the different options for the screening, the increased false positive rate of the screening test in the triplet pregnancy, their greater likelihood of being offered invasive testing, their greater likelihood of complications of invasive testing, the physical risk and psychological implications in the short and long term relating to the selective fetal restriction. Now, the healthcare professionals who screen for the Down, Edward, and Fetal syndrome in chorionic triplet pregnancy should map the fetal position, use knuckle transfrequency, for screening and calculate the chance of the Down syndrome, Adverse syndrome, and Preterm syndrome for each fetus. Refer the woman with the Dichorionic or Monoamniotic triplet pregnancy who wants screening for the syndrome to a tertiary level fetal medicine center. Now, do not use second trimester serum screening for Down syndrome in the triplet pregnancy. There should be referral after screening. Refer women with any type of the triplet pregnancy who have higher chance of these syndrome to a fetal medicine specialist in tertiary level fetal medicine center. Screening for the structural abnormalities should be there. The structural abnormalities include the cardiac anomalies in the twins and triplet pregnancy as in routine antenatal care. Consider scheduling ultrasound scan in the twins and triplet pregnancies at slightly later gestation age than in the singleton pregnancy, and be aware that the scan will take longer to perform. Now, allow 45 minutes for anomaly scan in the twins and triplet pregnancy to detect any sort of abnormalities or anomalies, and allow 30 minutes for the growth scans in the twins and triplet pregnancy. Now we will discuss screening for the preterm birth. Explain to the woman or pregnant people and their family members or care as appropriate that they have a higher risk of spontaneous preterm birth, and this risk is further increased if they have other risk factors such as spontaneous preterm in the previous pregnancy, or they are found to have short cervix on the cervical length screening. Now, do not use fetal fibronectin testing alone to predict the risk of spontaneous preterm birth in the twins and triplet pregnancy. And do not use home uterine activity monitoring to predict the risk of spontaneous preterm birth in the twins and the triplet pregnancy. Now I'll talk about the screening for fetal growth restriction and fetal transference syndrome in the first trimester. Do not offer women with the twins or triplet pregnancy screening for the fetal growth restriction or fetal transference syndrome in the first trimester. And diagnostic monitoring for the fetal growth restriction in the dichorionic twins and trichorionic triplet pregnancies will be discussed now. Do not use abdominal palpation or symphysiofundal height measurements to monitor for the fetal growth restriction in the dichorionic twins or trichorionic triplet pregnancy. Now, at each ultrasound scan from the 24 weeks of a woman with the dichorionic twins or trichorionic triplet pregnancy, the diagnostic monitoring for the fetal weight discordance using 2 or more biometric parameters and amniotic fluid level. To assess the amniotic fluid level, measure the deepest vertical pool DVP on each side of the amniotic membranes. Now, continue monitoring for the fetal weight discordance at interval that do not exceed 28 for a woman with the dichorionic twins, 14 days for the woman with a trichorionic triplet pregnancy. Now, calculate and document estimated fetal weight discordance for the dichorionic twins using this formula, like estimated fetal weight of the larger fetus minus estimated fetal weight of the smaller fetus divided by estimated fetal weight of the larger fetus multiplied by 100. Calculate and document estimated fetal weight discordance for the trichorionic triplet using this formula, like estimated fetal weight of the larger minus smaller fetus divided by estimated fetal weight of the larger fetus multiplied by 100, and estimated fetal weight of the larger fetus minus estimated fetal weight of the middle fetus divided by estimated fetal weight of the largest fetus multiplied by 100. So remember this formula. Increase diagnostic monitoring in the second and third trimester to at least weekly and include Doppler assessment of the umbilical artery flow for each baby if there is an estimated fetal weight discordance of 20% or more, and or the estimated fetal weight of any baby is below the 10th centile for the gestational age. Refer women with the dichorionic twins or trichorionic triplet pregnancy to a tertiary level fetal medicine center if there is an estimated fetal weight discordance of 25% or more, and the estimated fetal weight of any baby is below the 10th centile for the gestation age, because it is clinically important indicator of selective fetal growth restriction. Let us talk about diagnostic monitoring for the complication of the monochorionicity and in the twins and triplet pregnancy. A monochorionic twins or triplet pregnancy is one in which any of the babies share a placenta and a chorionic, that is outer membrane. This include the monochorionic twins and the dichorionic and monoamniotic triplets. Offer women simultaneous monitoring for the fetal transfusion syndrome, fetal growth restriction, and advanced stage twin anemia polycythemia sequence at each ultrasound assessment to monitor effectively for all complications of monochorionicity. For the fetal transfusion, offer diagnostic monitoring to women with monochorionic twins or triplet. Monitor with ultrasound every 14 days from 16 weeks until birth. Use ultrasound assessment with a visible amniotic membrane within the measurement image to monitor for fetal transfusion syndrome. Measure the DVP depth of the amniotic fluid on each side of the amniotic membrane, and increase the frequency of the diagnostic monitoring for the fetal transfusion in the woman's second and third trimester to at least weekly if there are concerns about the differences between the baby's amniotic fluid, that is a difference in the DVP depth of 4 cm or more. Include the Doppler assessment of umbilical artery flow for each baby. Now, refer the woman to a tertiary level fetal medicine center if the fetal transfusion syndrome is diagnosed based upon these things, that amniotic sac of one baby has DVP of less than 2 cm and amniotic sac of another baby has a depth of 8 cm or more before 20 weeks of pregnancy, or over 10 cm from 20 weeks onward. Refer the woman to her named specialist obstetrician for the multiple pregnancy in her second or third trimester for further assessment and monitoring if the amniotic fluid of one baby has a DVP depth in the normal range and amniotic sac of another baby has DVP depth of less than 2 cm or 8 cm or more. Now, we will talk about the fetal growth restriction in the monochorionic pregnancy. Do not use abdominal palpation of symphysis or fundal height measurement to monitor for fetal growth restriction in the woman with a monochorionic twins or the triplet pregnancy. At each ultrasound scans from 16 weeks, offer women with a monochorionic twin or triplet pregnancy diagnostic monitoring for the fetal growth discordance using 2 or more biometric measurement, and to assess the amniotic fluid, measure DVP on each side of the amniotic membranes. Continue monitoring women with monochorionic twins or triplet pregnancy for fetal discordance, weight discordance at interval that should not exceed 14 days. Now, calculate and document estimated fetal weight discordance in the monochorionic twins using this formula, that is estimated fetal weight of the larger minus smaller fetus divided by estimated fetal weight of the larger fetus multiplied by 100. The named specialist obstetrician should review the estimated fetal weight of dichorionic and monochorionic triplets and calculate estimated fetal weight discordance based on their understanding of implications of the chorionicity. Increase the diagnostic monitoring in the second and third trimester to at least weekly and include the Doppler assessment of fetal umbilical artery flow for each baby if there is estimated fetal weight discordance of 20% or more, and or the estimated fetal weight of any baby is below the 10th centile for the gestational age. Refer the woman with the monochorionic twins or triplet pregnancy to a tertiary level fetal medicine center if there is estimated fetal weight discordance of 25% or more, and the estimated fetal weight of any of the baby is below 10th centile for the gestation age, because this is clinically important indicator for selective fetal growth restriction. Now, twin anemia polycythemia sequence. For that, offer weekly ultrasound monitoring for twin anemia polycythemia sequence from 16 weeks of pregnancy using the middle cerebral artery peak systolic velocity to a woman whose pregnancies are complicated by fetal transfusion syndrome that has been treated by fetoscopic laser or by selective fetal growth restriction defined as estimated fetal weight discordance of 25% or more, and an estimated fetal weight of any of the baby is below 10th centile for the gestation age. For the woman with a monochorionic pregnancy showing any of the following, like cardiovascular compromise, unexplained isolated polyhydramnios, or abnormal umbilical artery, perform the ultrasound for middle cerebral artery pulsatility peak systolic velocity measurements to detect the advanced stage. So Doppler assessment is very important. Now, how would you go for preventing the preterm birth? Discuss with a woman or pregnant woman with the twins or triplet pregnancy that if cervical length is short, that is 25 mm or less, treatment with the progesterone may reduce the risk of preterm birth. Offer single cervical length scan between the 16 to 20 weeks to women or pregnant people with a twins or triplet pregnancy. Offer progesterone of 200 milligram vaginal capsule once a day at bedtime to women or pregnant people with a twins or triplet pregnancy and cervical length of 25 mm or less. And if the cervical length of 25 mm or less is found incidentally on the scan conducted between 20 to 24 weeks, offer progesterone 200 milligram vaginal capsule once a day at the bedtime. Do not offer intramuscular progesterone to prevent the spontaneous preterm birth, and do not offer these interventions like Arabian pessary, bed rest, cervical cerclage, and oral tocolytics. And corticosteroids, for that, inform the woman that as there is increased risk of preterm, so corticosteroid is very beneficial, but do not offer either single or multiple routine courses of corticosteroids. Inform women that there is no benefits in using untargeted administration of corticosteroids. Now, maternal complications will be discussed now, and first of all, hypertension is needed to be kept in the mind. Measure blood pressure and test the urine for proteinuria to screen for the hypertensive disorders at each antenatal appointment in the twins or triplet pregnancy, in line with the NICE guidelines on the antenatal care. And advise the women with the twins or triplet pregnancy to take the low dose aspirin from 12 weeks until the birth of the babies if they have two or more of the risk factors specified in the section of antenatal care agents in the NICE guideline in the hypertension in pregnancy. You can study in detail from there. Now, what are the indications for referral to a tertiary level fetal medicines? It's very important to keep in mind that we need to seek a consultant opinion from tertiary fetal medicines for the pregnancy with a shear amnion and those with the fetal growth discordant, fetal anomaly, and fetal transfusion, twin reverse arterial perfusion, conjoined twins, or the suspected twin anemia polycythemia. Now, planned birth information and support is very important from 24 weeks in a twins or triplet pregnancy. Discussed with the woman her plans and wishes for the births of her baby. Ensure these things are discussed by the 28 weeks, that is the place of the birth, the timing of the birth, analgesia, intrapartum fetal monitoring, and management of the third stage of the labor. Now, the timing of the births, that is very important to know, and it should be discussed with the woman. Antenatal information for the woman should be provided. Explain to the woman with twins or triplet pregnancy that about 60 in 100 pregnancies result in spontaneous birth before 37 weeks. Explain to the woman with a triplet pregnancy that about 75 in 100 pregnancies result in spontaneous birth before 35 weeks. Explain to the woman with a twins or triplet pregnancy that spontaneous preterm and unplanned preterm births are associated with increased risk of admission to neonatal unit. Explain to the woman with the uncomplicated Chorionicity diamniotic twin pregnancy that planned birth before 37 weeks doesn't appear to be associated with increased risk of serious neonatal outcome, and continuing pregnancy beyond 37 plus 6 weeks increase the risk of the fetal death. Explain to the woman with the uncomplicated monochorionic diamniotic twin pregnancy that the planned birth from 36 weeks does not appear to be associated with increased risk of the serious adverse outcome, and continuing pregnancy beyond 36.6 weeks increase the risk of the fetal death. Now, explain to the woman with uncomplicated monochorionic monoamniotic twin pregnancy that planned birth between 32 to 33 plus 6 weeks would be the most appropriate time. Explain to the woman with an uncomplicated chorionic triamniotic or dichorionic diamniotic that the best time for the delivery is about 35 plus 6 weeks. Now, explain to the woman with a monochorionic triamniotic triplet pregnancy or the triplet pregnancy that involve a shared amnion, that the timing of the birth will be declared and discussed with each woman individually. Okay, so when to offer the planned birth? Offer planned birth at 37 weeks to the woman with uncomplicated dichorionic diamniotic twins pregnancy. Offer planned birth after a course of antenatal corticosteroid at 36 weeks with uncomplicated monochorionic diamniotic twin pregnancy, between 32 and 33 plus 6 weeks for the woman with uncomplicated monochorionic monoamniotic twin pregnancy, at 35 weeks for the woman with uncomplicated trichorionic triamniotic or dichorionic triamniotic triplet pregnancy. Now, offer an individual assessment to determine the timing of the planned birth in a woman with these things like a complicated twins with or triplet pregnancy, monochorionic triamniotic triplet pregnancy, a triplet pregnancy that involve shared placenta. Now, the timing of the planned birth should be discussed for the woman who declined planned birth at timing recommended in the NICE recommendation. Offer weekly appointment with a specialist obstetrician, and at each appointment the fetal growth, amniotic fluid, and Doppler umbilical artery flow for each baby should be screened out. Now, the mode of the birth will be discussed. In case of the twin pregnancy like dichorionic diamniotic or monochorionic diamniotic, both planned vaginal birth and planned cesarean section are safe choices if the pregnancy remains uncomplicated and has progressed beyond 32 weeks and there is no obstetric contraindication to the labor and the first baby is cephalic and there is no significant size discordant between the two twins. Now, explain to the woman with uncomplicated twin pregnancy that for a woman giving birth after 32 weeks, more than third of the women who plan a vaginal birth go on to have a cesarean section. Almost all women who plan a cesarean section do have one, but a few women have a vaginal birth before cesarean section can be carried out. A small number of the women who plan a vaginal birth will need an emergency cesarean section to deliver the second twins and vaginal birth of the first twins. Offer cesarean section to the woman if the first twin is not cephalic at the time of birth, and offer cesarean section to the woman in established preterm labor between 26 to 32 weeks if the first twin is not cephalic. Offer individualized assessment of the mode of the birth to the woman with suspected, diagnosed or established preterm labor before 26 weeks. In case of the monochorionic monoamniotic twins pregnancy, offer cesarean section to these women at the time of the planned birth between 32 and 33 plus 6 weeks, or offer any complication. Offer C-section if any complication is diagnosed during pregnancy or if she wishes the cesarean section. In case of the triplet pregnancy, offer cesarean section at 35 weeks or if any complication is diagnosed. And fetal monitoring during labor in the twin pregnancy is very important. By 28 weeks of the pregnancy, discuss the continuous CTG monitoring in such patients. Explain to the woman that continuous CTG is used to monitor the baby's heartbeat and their labor contraction, and that it allows simultaneous monitoring of both babies. It is normal to see changes of the fetal heart rate pattern during labor, and this does not necessarily mean there is a problem. Findings from the CTG are used to help make decisions during labor and birth, but these will be based on her wishes and her condition. Intrapartum monitoring is also very important. Offer continuous CTG to the women with a twin pregnancy who are in established labor and are more than 26 weeks pregnant. Perform portable ultrasound scan when the established labor starts to confirm which twin is which, the presentation of each twin, and to locate the fetal heart. Do not offer intermittent auscultation to the women with a twins pregnancy who are in established labor and more than 26 weeks pregnant. For the women between 23 and 25 plus 6 weeks of pregnancy who are in established labor, involve senior obstetrician to do discussion with a woman. When carrying out CTG, use dual channel CTG and document the CTG and in the clinical record which CTG trace belongs to which baby. Consider separating the fetal heart rate by 20 beats per minute if there is difficulty in differentiating between them. Classify and interpret CTG in line with the NICE guideline, and review the CTG. Carry out systemic assessment of both CTG at least hourly and more frequently if there are concerns. Now, management based on CTG. If abdominal monitoring is unsuccessful or there is concern about synchronicity of the fetal heart, involve senior obstetrician or senior midwife. If the CTG trace is categorized suspicious in the first baby during established labor, involve the senior obstetrician. If CTG trace is characterized as pathological, involve senior obstetrician, and discuss the management option and the use of fetal blood sampling of the baby from 34 weeks if the benefits are likely to outweigh the potential risks. When offering fetal blood sampling in the twins pregnancy, discuss with the woman and her family members or carer if the fetal blood cannot be obtained and she is likely to need a cesarean section. If the result of the fetal blood sampling are not available within 20 minutes, then offer immediate C-section to the women with a twin pregnancy. If the CTG trace is characterized as pathological, involve senior obstetrician and do assessment whether vaginal birth is appropriate or not. If vaginal birth is not appropriate or cannot be performed, then go for immediate C-section. And if the CTG is characterized as suspicious, involve the senior obstetrician, and if vaginal birth of the second baby cannot be achieved within the 20 minutes, discuss performing cesarean section with the woman and her family members or the carer. And after the birth of the baby, continue monitoring the second baby using CTG if there is suspicious or pathological CTG and vaginal birth cannot be achieved within the 20 minutes. Discuss performing cesarean section with the woman and her family members or the carer. After the birth of the both babies, consider double clamping the cord to allow umbilical cord blood gases to be sampled. Analgesia. Discuss the different methods of analgesia. Offer epidural analgesia if the woman opts for the vaginal birth. And how would you manage the third stage of the labor? Do the assessment of the risk factors for the postpartum hemorrhage, and there should be individualized assessment for the risk factor for the PPH. Now management of the third stage should be the active management of the third stage of the labor by using additional uterotonic for the women who have one or more risk factors for PPH. The blood transfusion availability should be ensured in case of the need, and urgent administration should be performed. So that was all about the NICE guideline about the twins and triplet pregnancy. Subscribe on Obs and Gynae and follow the Facebook page of on Obs and Gynae.